ventilator cycling. Tutorial 4. Cycling mechanisms. Previously, we looked at how ventilators cycle from expiration to inspiration, and this is known as triggering. And the conventional way this is achieved is by setting a respiratory rate. And of course, that means that the ventilator triggers at a particular period of time. So that's time triggering. Where the patient starts to interact with the ventilator, the trigger needs to respond to the patient's spontaneous efforts. And the original way ventilators were triggered was using negative pressure, but that has been supplanted by and large over the last 30 years with flow-by triggering. And that was explained extensively in the last tutorial. This time we're going to look at cycling mechanisms. And cycling is how the ventilator cycles from inspiration to expiration. In other words, how the ventilator knows that it's time to end a breath. And we're going to look at volume and time cycling and then flow cycling. I will mention pressure cycling just briefly in this tutorial as well. Again, cycling is how the ventilator transitions from inspiration to expiration. And be aware that most of the time that we have patients on controlled mechanical ventilation, we're using time cycling. When an inspiratory time is set or an I/E ratio is applied, that's inspired to expired ratio is applied, then we do this in both volume control and pressure control. In volume control, for example, we might set 10 breaths at an I/E ratio of 1 to 2. And that means that usually, although not always, there is a 2-second inspiratory time and a 4-second expiratory time. When I say not always, so on servo ventilators in SIMV, it's a little bit different, and I'll talk about that in a later tutorial. But most of the time, when you set 10 breaths and the I/E ratio is 1 to 2, it's 2 seconds inspiration, 4 seconds expiration. Alternatively, an inspiratory time may be set, for example, 1 second, and sometimes an inspiratory pause is added. Be aware, of course, that pressure control is always time cycled. Bilevel, which is bilevel pressure control, is time cycled, but you can control the inspiratory time and the expiratory time. And again, I will talk about that in a later tutorial on modes of ventilation. In this cartoon, you can see here that this is constant flow in volume control, and the breath ends immediately that the tidal volume has been achieved. In the second picture, there's a pause between the end of the breath and expiration. The first breath is volume cycled, so as soon as the breath goes in, it cycles to expiration. The second breath is time cycled. You will note that the duration of flow is the same, and because flow continues until the tidal volume has been achieved, and the tidal volume remains identical for both breaths. In many ways, volume cycling is a little bit old-fashioned. It's used exclusively, of course, in volume control modes of ventilation. You set the tidal volume and the peak flow. For example, 500 mils at 30 litres per minute is 1 litre in 2 seconds. So the tidal volume is delivered in 1 second. And then the ventilator cycles to exhalation if no pause is added. This is an example of a patient who's on volume control ventilation with a constant flow and a peak flow of 51 litres per minute. You can see that the ventilator immediately cycles to exhalation following delivery of the breath, so the breath is volume cycled. In this situation, one does not set an inspiratory time or an I/E ratio. The duration of inspiration is determined entirely by the peak flow. It's higher. If you give a higher peak flow, the breath is shorter. If you have a lower peak flow, the breath is longer. But there is no set time for this particular breath. It's all based on volume cycling. In volume control ventilation, you can achieve time cycling by adding an inspiratory pause. The pause is deducted from the inspiratory time, determined by either setting an I time or an I to E ratio. This results in the inspiratory flow time being reduced to accommodate the pause. I thought it might be worth just talking about inspiratory time versus I to E ratio. A lot of anesthesiologists are keen on the I to E ratio. It's a very fundamental thing in anesthesiology training, but it is slightly problematic. It's important to understand that if you set an inspiratory time, this will always be the same regardless of the respiratory rate. So for example, if the rate is 10 breaths per minute and the inspiratory time is 1 second, the I to E ratio is 1 to 5. If the rate is increased to 20 breaths per minute, the I to E ratio is 1 to 2 because the inspiratory time does not change. This will dramatically increase mean airway pressures and may cause hypotension, so it's worth keeping in mind. If you set an I to E ratio, for example, 1 to 2 and the respiratory rate is 10, then the inspiratory time is 2 seconds. If the rate is turned up to 20, the inspiratory time will drop to 1 second, and the ventilator will deliver flow over a shorter period of time, resulting in a higher airway pressure. Now, normally this doesn't matter, but if you're in a situation where you're struggling against worsening chest wall compliance, for example, during laparoscopic surgery where the CO2 level is rising and the chest wall compliance is deteriorating, you may be fighting airway pressures. Again, these airway pressures don't really matter because they're just reflecting the poor compliance of the chest wall rather than the lungs, but you may have a lot of airway pressure alarms going off. In this example, you can see that the patient has an I to E ratio of 1:2.1. There is constant flow with a peak flow of 48 litres per minute. You will notice that there is an inspiratory pause on the settings tab, and this is for 0.5 seconds. So this is time-cycled volume-controlled ventilation. From these data, you can figure out that the inspiratory time is approximately 1 second and the inspiratory flow is delivered in half a second with a half-second pause. This is an example of time-cycled volume-controlled ventilation with a decelerating flow pattern. You can see here that the I to E ratio is 1:1.4. The flow pattern is decelerating and the peak flow is 51 litres per minute. There's also a pause of 0.4 seconds that you can see on the settings part of the screen. Pressure control ventilation is always time cycled. This is a pressure assist control ventilation, and the inspiratory time is 2 seconds. The rate is 15, which means that the I to E ratio is 1:1. You can observe the pressure waveform and identify inspiration and expiration. The fine control of inspiratory time is a really useful aspect of pressure controlled ventilation. In this example of pressure controlled ventilation, we've applied a really long inspiratory time. As the respiratory rate is 15 breaths per minute, that means the expiratory time must be very short, and the I to E ratio is 3:1. This is known as inverse ratio ventilation. You can probably just pause this for a second and figure out the expiratory time yourselves. Note that the pressure waveform here is very much dominated by inspiration with very, very short expiratory times. This is a strategy that is sometimes used in patients with acute respiratory distress syndrome where their chest wall and lung compliance may be very poor. Why would you use such long inspiratory times? Well, by holding the breath in inspiration for a prolonged period, the inspiratory reserve volume is recruited for gas exchange. So that part of the lung that's not normally involved in gas exchange, and particularly where there's tremendous amounts of atelectasis or consolidation of the lungs, you can use that part of the lung that you normally would not use for gas exchange and use it to help you oxygenate the blood. Gas redistributes from highly compliant to less compliant lung units with very long time constants, and this results in better alveolar gas capillary exchange dynamics and usually better oxygenation and ventilation in very, very diseased lungs. The other mode that's worth talking about is volume guaranteed pressure control. This is a mode we will discuss in tutorial 6. And it's always time cycled. On the Puritan Bennett ventilator, this mode is called ACVC+, and you can see here it's known as pressure regulated volume control on the servo. You can see here the inspiratory time is 1 second. So this is time cycled. It looks like pressure control. It sort of behaves like volume control because the tidal volume is set. You can see there it's set at 370 mils, but it is decelerating flow, time-cycled, pressure-controlled ventilation. Ventilators rarely pressure cycle. It is caused usually by stacking breaths. The patient attempting to breathe when the lung is already full of gas. As all ventilators set a pressure limit, and when they pressure cycle, they do so to prevent ventilator-induced lung injury. On most modern ventilators, the most common cause of pressure cycling is when the inspiratory time is excessively long and the patient attempts to exhale while the ventilator is in a zero flow state. This results in a spike in the airway pressure. Up to a certain amount, the flutter valve on modern ventilators will let off some gas but keep the airway pressure the same. But if the pressure limit that has been set in the ventilator is exceeded, the ventilator will cycle to exhalation. This is an example of pressure cycling. You can see here there was a terminal upstroke on the pressure waveform. The breath is going on too long and the patient is trying to exhale while gas is being held in the lungs. This is time-cycled ventilation. The ventilator will cycle to exhalation if the airway pressure, in this case, increases more than 3 centimeters above the inspiratory pressure or pressure support level above PEEP, and that's where we set our P max in our alarms. The other form of cycling is flow cycling, and this is seen in pressure support ventilation. Pressure support ventilation is a form of assisted spontaneous breathing, but please do not call this mode CPAP pressure support or ASB. It is pressure support ventilation. That's the generally agreed term for this. The patient initiates a breath, a flow of gas is generated to a pre-specified airway pressure, and the tidal volume is variable. During inspiration, the rate of flow slows down. So when the flow slows to like a certain proportion of peak flow, for example, 25% of peak flow, and that's determined by the operator, the ventilator cycles to exhalation. This is what pressure support looks like, and we will visit this mode in more detail in a later tutorial. But the driving pressure here is, and that's the pressure support level, has been set at 14 centimeters of water, and that is delivering 486 mils tidal volume. You will note that the I/E ratio in pressure support varies from breath to breath, as does the tidal volume. In this tutorial, I want you to focus on the flow waveform. This is the flow waveform, and the number here in purple, this is the expiratory sensitivity. Let's just zoom in on this. The expiratory sensitivity is the mechanism by which the ventilator cycles to expiration during pressure support. Think about the way you breathe. If you take a large breath, usually inspiration is rapid and expiration follows quickly afterwards. If you take a short, slow breath, inspiration is slower and you tend to hold the breath in longer. That's the concept between pressure support flow cycling. One specifies a point at a specific percentage of peak inspiratory flow that will vary from breath to breath. The patient will trigger every breath, but the ventilator will switch flow off and the ventilator will cycle to expiration at that specific proportion of peak flow. And this is the expiratory sensitivity that I have just mentioned. In this example, the expiratory sensitivity is set at 25% of peak flow. On the flow waveform, you will see that the peak flow here is just shy of about 60 liters for this particular breath. 25% of this is approximately 15 liters, and that is the flow rate at which the ventilator cycles to exhalation. In this example of pressure support ventilation with an expiratory sensitivity set at 25%, you can see in this initial breath, patient has a peak inspiratory flow of 60 liters. 25% of 60 liters is 15 liters. So when the flow reaches 15 liters as it decelerates, it shuts off and the patient cycles to exhalation. This translates to a tidal volume of about 450 mils for this particular patient. The next breath that the patient takes has greater inspiratory effort, and the peak flow is 80 liters. Because 25% of 80 liters is 20 liters, the flow stops at 20 liters, but the tidal volume is larger due to the greater pressure ramp in the second breath. If you were to look at the pressure waveform here, you can see here on the pressure waveform that the patient is making an inspiratory effort below the CPAP or PEEP level, but the effort is greater on the second breath, and there is more rapid flow as a consequence and a shorter breath. And that's flow cycling. And we will look at problems related to flow cycling in a later tutorial. Let's wrap this up. This particular tutorial looked at ventilator cycling. Mechanical ventilators cycle from inspiration by volume cycling in volume control ventilation, in time cycling in vertiole control modes of ventilation, whether they are volume control or pressure control, and flow cycling, which is specific to pressure support ventilation. Next time I will discuss modes of ventilation, volume control modes, volume assist control, and SIMV volume control. Don't forget to move on to the next tutorial and subscribe if you're watching this on YouTube.